Recording works. Okay. Now let's figure out how to share my screen. Okay. Can you all see the PowerPoint? Okay.
Yes.
All right. So like Dr. Hirschberger said, one of the applications of motivational interviewing is screening, brief intervention, and referral to treatment. So SBIRT is an acronym for addressing alcohol use and drug use in the clinic. One of the reasons why, the benefits to SBIRT is that offering routine universal screening, make sure that you catch all of your patients rather than just those that we choose to ask about alcohol or drug use. You're going to use some validated screening tools. It helps see alcohol more on a continuum from low risk to risky use rather than yes or no, do you have a problem or don't you? We use MI in the brief intervention when addressing those issues with patients. And then it gives you a place of where you really know that you should refer to specialized treatment. So if you drop your address in your physical mailing address in the chat, I can send you a little card. And these cards are pretty helpful because they have the number of drinks per week and the limit. So a lot of people don't know how many drinks per week you really should have as a male or a female, what's recommended. So the recommendation is 7 in a week for a woman and 3 in a day or less. And then 14 in a week and 4 for a day for a man. And it's kind of a both and. So you can't save up all of your drinks for one day and drink 14 in a day for a man and still be below the limit. You would be exceeding the daily limit. And then for men over 65, it drops to that of women, and then pregnancy is obviously 0. So many people ask why these numbers, and these numbers, above these numbers, the risk curve gets steep. So above 4 and 5 drinks for a woman and a man, you begin to accumulate some additional higher risk of consequences. So unintentional injuries, death, being a target of aggression, alcohol use disorders, etc. So on the card as well, there is what size of a drink we're talking about. So one 12-ounce beer is 1 drink, one 12-ounce malt liquor is 1.5. Wine is 1 5-ounce glass and 1 mixed drink for liquor. So it's important to ask patients, what are you drinking or what size are you drinking? I can remember a gentleman over at the 5 Rivers Clinic. He kept telling the resident that he was only having 2 beers a day, but they were 240s. So that's a bit different. So screening, what does screening look like? So for alcohol, it is the Alcohol Use Disorders Identification Test. And I'm going to show you in just a minute how this looks what this looks like in a workflow at the clinic. So hopefully your MA can do this portion for you. So it just asks the one question, universal screener for men, how many times in the past year have you had 5 or more drinks in a day? So looking for exceeding that daily limit, and then more than 4 for a woman. It also asks about recreational drug use. How many times in the past year have you used a recreational drug or used a prescription medication for non-medical reasons? And then it's got a PHQ-2 on there as well. And it's just yes or no. So if the MA can hand this out, or even your front desk, if they score yes, then the MA can give them a full screen. So this is the brief screen, and then this is the Alcohol Use Disorders Identification Test. So this is a 10-question screener of drinking or alcohol use over the past year. It's scored 0 to 4 for each question, and many of the questions you'll recognize, they're cage questions that you're used to. So they've got the size of the drinks there at the top, and asking questions like, how many drinks containing alcohol do you have on a typical day when you are drinking? How often do you have 4 or more drinks in one occasion? How often during the last year have you found that you were not able to stop once you started? So many of the CAGE questions here. These, you just add up what they circle here at the bottom, and it places them into a Roman numeral category down here that we'll use in a minute. The drug abuse screening test is the DAST, and this is a screener for drug abuse over the past year. And it's 10 items. Have you used drugs other than those required for medical reasons? Do you abuse more than one drug at a time? Are you unable to stop? So again, many of the same questions, and it has the drugs listed there at the top. When working with teenagers, there is an S2BI, and it includes the CRAFT questionnaires. So if you ever see teens, the CRAFT questionnaire is the Car, Relax, Alone, Forget, Friends, Trouble test. And that's just kind of an acronym to remember what the questions are about. But this S2BI asks about tobacco, alcohol, and marijuana. If all of those are no, you can skip the next part. If any of them are yes, then it goes on to ask about prescription drugs, illegal drugs, inhalants, and herbs. So I can send these forms to you if you'd like to use them, but they're all located at the Esper, Oregon screening form website. So when you add up all of those numbers, it places them into a Roman numeral category that correlates to this pyramid. And these are kind of the zones of substance use. So this bottom category is low risk, and they'll fall into this category when they either have no use or when their alcohol use is below the low risk limits or within the low risk limits. There are no low risk limits that apply to drug use. In the risky category, this is defined by when they're exceeding those low risk limits. This would be any adolescent use or any recreational drug use. In this category, they're likely not yet dealing with any consequences. The third category, harmful, is repeated negative consequences from use. This is when they're beginning to develop, signs and symptoms of a mild or a moderate substance use disorder. So, they're not going to work, their spouse is concerned, they might have a DUI. So many of the things where they're beginning to develop some consequences. And then severe is, correlating with a moderate to severe substance use disorder. And this is when someone's using, they're developing tolerance and withdrawal. They can't hold down a job. Their patient's life orbits around use. So this is pretty severe alcohol and drug use. Many residents wonder, this is all well and great. I'm already, really busy in the clinic. How will I address this too? So when we look at the intervention of the people that we really want you to supply an intervention to, we're really looking at this risky and harmful category here, this 9% and 8%, so 17% of the population is really who we feel like you're going to interact the most with in the clinic to have to kind of do anything with. So this, 78% down here, you're just going to affirm that they're drinking below those limits, and we'll go through those interventions here in a second. So with low risk use, we just want you to recommend that, it's great. You're drinking below those low risk limits. I, encourage you to stay below those. You're likely not to see any consequences. In the risky category is where you would supply a brief intervention, which is housed in motivational interviewing, and we're going to go through the steps of that. With the harmful category, you'd want to supply the brief intervention and recommend them to cut back, offering them, to follow up in a few weeks to see if they're able to get down to the risky category. And if they are, then, you can continue with what you're doing. If you follow up and they're not, then that would kind of more bump them into the severe category where you would refer to specialized treatment. So knowing where those referral places are in your community with your clinic is important so that you know where you can refer to. So like I said, ideally your front desk staff would distribute the annual screen. If any of those are marked yes, then your MA could distribute the full screen that by the time you walk into the room, Your audit or your dash should be completely filled out. You can quickly score it. If you've got a handy dandy card that I can send you, all of that information is on there, and then you'll know what to do. So hopefully your job would be just to supply the brief intervention if needed. What does the brief intervention look like? So the brief intervention is housed in motivational interviewing. There's 4 steps. First, you want to raise the subject, provide some feedback on where they scored on the screener, enhance motivation, and then negotiate a plan. So under raising the subject, you can use the screener as a conversation starter and just ask permission. Is it okay if we talk about that form that you filled out for me before I came in today? Most of the time patients will say yes, especially if they filled it out. So your next question can be, just tell me about your substance use, or tell me about your drinking. Tell me about your drug use. You want to state the zone of use that they fall into. So you want to let them know, hey, you're falling into the harmful category, or falling into the risky category. One of the great places that, kind of falls into motivational interviewing is asking if they see a connection between their use and the health issue that they're presenting for that day. So what connection do you see between your blood pressure and your drinking? And offering them too, this might be some of the reason why we're having difficulty getting your blood pressure under control. We want to state the low risk limits and show them where they would need to fall into in order to fall below those categories, and then give your recommendation on whether we want them to just reduce or completely cut out alcohol altogether. Under enhanced motivation, you can ask them to reflect about the pros and cons. So some of the questions we like are, what do you like about your drinking? What don't you like? And the same for drug use. What do you like about using cocaine? What don't you like? And then ask on a scale of 0 to 10, how ready they are to maybe make a change. And then ask why not a lower number. So that why not a lower number will give you more change talk. There is a readiness ruler at the bottom of the card, and you're going to have patients that fall in that 0 to 3 category. You're going to have patients who are not ready, and having some tools to be equipped with how to deal with them, offering some patient autonomy. The decision to change is ultimately up to you. Given that you're not really ready to cut back on your alcohol use, we might have a difficult time getting your blood pressure under control. Finding those that are in those middle categories, asking them why not a lower number, might help push them up a little bit. And those that are in that 8 to 10 category, really you can move on to just developing a plan for change. So if the patient is ready, asking them, what would change look like for you? How many drinks would you cut back a day? What would you do instead? Restating your recommendation, and then ask to follow up. So this is the card that I'm referring to. It's got the pyramid, the percentages, what we recommend that you do, the low risk drinking limits, the sizes, and a readiness ruler all on the front. And on the back, for you to look at while you're showing the front of the card to the patient, is the steps and some suggestions for questions that will help jog your memory. And it's kind of a little plug and chug conversation there. On the inside is some tips for motivational interviewing, kind of the phases there that you can walk through, and then some things to do if you're stuck, what to emphasize and what to avoid. So if you give me a moment to figure out how to change which screen I'm sharing, I'm going to share with you a video. Okay, you'll have to let me know if you can hear this.
Year-old female who is being seen for a follow-up visit related to her hypertension. She also presented 6 months ago with a fractured arm from a fall on her steps. During this visit, Jill scored in zone 3 on the audit, the harmful category.
So Jill, I know you're here to talk about your blood pressure today. Before we get into that, I see you filled out our annual screening forms here. So if you're okay, can we take a minute to talk about that?
Sure.
Okay, great. It looks like the way you filled out the alcohol form puts you into our third zone of drinking. Can you tell me a little bit about your drinking habits? Where you drink? What do you like to drink?
I drink wine mostly. Okay. I go down to the little pub down the street. Mm-hmm. Have a few glasses of wine.
Okay. Kind of socializing. Mm-hmm. All right. How often do you do that?
3 or 4 times a week, probably.
Okay. And in a regular night, how many glasses of wine would you guess you drink?
3 or 4 or 5. Mm-hmm. Maybe on a weekend, maybe 6.
Okay. Okay.
Over a period of time. Mm-hmm.
Okay. So let me just show you on this card here. From a medical perspective, we know that there's good evidence that shows that women your age who drink more than 3 drinks on any one occasion, at any sitting, or more than 7 in a week, are likely to run into health problems from their drinking, either problems they're having right now or maybe in the future.
Are you serious?
Yeah, surprising.
7 drinks in a week doesn't seem like that much.
It sounds like you're drinking a bit more than that right now.
Yeah, I didn't think it was much, but that makes it look like I'm drinking way too much. Mm-hmm.
From this drinker's pyramid over on this side of the card, you can see that the score on your screening sheet shows that you're up in the harmful category of drinkers. So that it's likely you're drinking, in quantities, probably more than about 90% of the folks who come in to see me here at the clinic.
Well, I know my drinking has increased a little since I got divorced and moved to Portland, but I don't think it's that much of a problem.
It doesn't feel like a problem to you right now.
No, not really.
Yeah, okay. And then the other thing I should mention, Jill, drinking more than these quantities, it's possible it could be pushing your blood pressure up a bit. And I'm wondering if that might be affecting the difficulty we're having getting your blood pressure down right now.
I didn't realize that drinking had anything to do with blood pressure.
Mm-hmm. Yeah, it can sometimes.
Oh, well then, I guess that could be a problem.
My perspective as a doctor, it would be good if you could think about cutting back a little bit or doing something different about your drinking. What do you think about that?
I guess I could cut down some.
Okay. So on a scale of 0 to 10, 0 being not ready at all to do that and 10 being very ready, where would you lie on that scale?
I'd probably a 6.
Okay. Okay, so I think that's great. So why would you be up at a 6 and not down at a 2 level? What kinds of things would push you to be up there?
Well, I didn't realize that drinking was related to my blood pressure problems.
Yeah.
And I did fall earlier this year on my way home from the bar and hurt my shoulder. I don't think the drinking made me fall, but it probably didn't help the situation.
Okay.
And well, my son keeps telling me that I'm drinking too much. And it's scary to think that my drinking is harmful. It's a big word.
Yeah, yeah. So you've got some good reasons to try to cut back a little bit.
Sounds like it to me.
Yeah. And it sounds like you're willing to maybe try not going to the bar quite as much and maybe drinking a little bit less when you go to the bar.
I think I can try to do that.
Okay. Yeah. So to what levels do you think you could do that? Where would you want to go with your drinking?
I guess I could use those numbers, and I can't make any promises, but I could try to drink less than 3 in a night and less than 7 in a week.
Okay. Okay.
I mean, I could only drink 2 or 3 times a week.
Mm-hmm. So you would drink maybe just a couple times a week and maybe a little bit less on each occasion? Is that what you're saying?
I can try that, yeah.
Okay. Okay.
I don't think I need to quit, but I think I can try and cut down.
And you think you're able to cut down to those levels of no more than 7 a week?
That's what I'll shoot for.
Okay. I think that sounds like a great step for you as your doctor. Why don't we revisit this the next time you come in to talk about your blood pressure in about 6 weeks or so, and we can see how you're doing with it.
Okay.
All
Sounds
right.
good.
Well, let's get back to your blood pressure then and see what we need to do about that.
Okay.
Okay, so the video with Esper is obviously a little bit more directive than we've kind of suggested with motivational interviewing, but it gives you a place where you can make your recommendations and then ask the patient to follow up. So, what questions do you have about Esper? Easy peasy, huh? One of the things that we do hear from medical students who rotate in clinics where universal screening is done is that they do say how helpful it is when the screening is just an automatic process of the office. It's not something else you have to do. It's infused in the workflow. And so you just have to do the brief intervention portion as the physician. So students do comment that it is nice when offices do already do that. Okay. I'll include the pediatric video as like a resource link on our future website, but that's all I have for Esper.
So Dr. Bricker, do you want to launch into? I think you're still muted too, by the way.
Yes. Do I want to launch into Presto? Am I still muted? Okay. Yeah, I'm trying to share my screen.
The share button is up there right by the big red leave button. There you go.
All right, this is not where I want to be, but can you see that? Okay, so we just heard about Espert, and now we're going to hear about Presto, which is something that that we designed a couple of years ago, modeled after Espert. So it's promoting engagement for the safe tapering of opioids and benzodiazepines. For some reason, I'm having trouble advancing the slide here. So if you've been around for a little while, I'm sure you have encountered patients that are taking chronic scheduled medications, and you know that there can be a number of challenges. And this slide sort of highlights some of them. So first off, patients' agenda may be totally different than ours. When we're encountering a patient, if they've been on these medications, chances are they aren't in a hurry to stop them. And then, so sometimes patients' goals with regard to scheduled medications don't align very well with our goals. And then another challenge, of course, is that both benzodiazepines and opioids, just a fact of biology is that they are going to develop some tolerance, and then tolerance basically means that it requires more and more higher doses to achieve the same biological effect. And so that's not really saying anything about addiction or abuse or anything like that. The tolerance is just a biologic phenomenon. And along with that is dependence, meaning that if they develop dependence, then they will get withdrawal symptoms if they're not getting the medication. A lot of the patients that have chronic pain also have psychiatric comorbidities, and in particular, depression and anxiety. and also PTSD. So sometimes those diseases create challenges when we're dealing with pain because there's sort of overlap in what the medications can do and what patients are experiencing. When we're dealing with these scheduled meds and patients are dependent, we can see behaviors that are aberrant, meaning things like running out of medications early, sometimes truthfully or sometimes falsely, but offering excuses for why they need extra medications and things like that. And then if we're doing what we're supposed to do, if someone is on chronic scheduled medications, we should be at a minimum checking urine drug screens once a year. And there's always the chance that we're going to find something there or not find a substance there. And then how do we deal with that? And then, of course, the whole reason patients are on these medications to begin with is because of chronic pain. And so chronic pain is a challenge for providers to deal with. So the opioid overdose epidemic has not gone away. It just was getting a lot more attention before the pandemic. And so these numbers up through 2019, we can see that the yearly annual overdose death rate was still climbing, and indeed it still is. So this bulletin, I think the graph has not been updated yet. At least I haven't been able to find it on the CDC website. But there was this bulletin that last year, that overdose deaths have now topped 100,000. And then, of course, the overdose deaths, there's different contributions, but a large number of those are due to opioids. A large number of those are combined medication use, like both benzodiazepines and opioids. And then the nature of the opioids has changed over time. So it is indeed true that more of these deaths are being related to things like fentanyl and synthetic opioids, and compared to in years past where it was more prescription medications and heroin. And then this issue is still of high importance, and pain management and substance use, impacts all physicians in their dealing with patients. But yet it seems like a lot of programs don't have dedicated curriculum talking about this. And so I'm not sure a lot of programs have addressed this yet, but a year ago, the ACGME was starting to think about making mandates and program requirements for having formal curriculum dealing with this. So, again, why do we care so much about chronic opioids? So we've talked a little bit about overdose death, and obviously substance use disorder, specifically opioid use disorder. And we do know that certainly not all patients that are on chronic pain medications develop this, but it definitely is a risk factor. If you're prescribed high doses for long periods of time, there is definitely an increased risk of developing opioid use disorder. But there's lots of other potential negative consequences, such as aggravating sleep apnea, hypogonadism, sexual dysfunction. If the hypogonadism is prolonged, then you can get osteopenia, osteoporosis, fractures. There's a correlation with falls. Opioids are on the Beers list for medications to be try to avoid in elderly patients. And then opioid use can aggravate depression. And then there's this concept of hyperalgesia, which is basically if you're on high doses for long periods of time, it can sort of reset your mu receptors and actually consequently provoke pain or alter the perception of pain. So 6 years ago, the CDC came out with a guideline for opioid prescribing. Before that, there really wasn't a universal guideline that was well accepted and well known. But since that time, this has become the standard care. And so it's not that physicians and primary care physicians should never be prescribing chronic opioids. It's just clearly it carries a risk, and there are things that we're expected to do. So we'll just quickly run through this. The points of the guideline are that first we should try other therapies, including non-medications. So whatever that might be, physical therapy or acupuncture or things like that. And then if we're going to use a chronic opioid, we should, before going there, before even prescribing it, we should establish with patient what the treatment goals are. And these should emphasize function, not 100% pain relief, because that's really not a reasonable goal. And then, of course, there's patient responsibilities. They need to follow up. They need to get urine drug screens. They need to do things like that. And there's physician responsibilities. We need to be monitoring patients carefully for risk and benefit. We need to be documenting things like that. If we're going to prescribe, we should use the short-acting opioids. So things like the patch or long-acting formulations of IR, things like that should carry greater risk. So if we're going to treat, it's recommended that we use short-acting medications. And then, of course, the higher the daily milligram equivalents of morphine, MME, the greater the risk. And so in particular, above 50, the risk starts going up. And then especially as you approach 90, to the extent that, unless we are a specific pain specialist or have specific expertise, the guideline discourages individual providers from prescribing above 90 MME. For acute pain, we should not give more than 1 week's worth of medication. And this is sort of why in Ohio, we have the requirement, if you're going to give more than that, you have a requirement to document that you accessed ORs and sort of explain what you're doing and why you're doing that. And like everything we do in medicine, we should always compare the risk and the benefits of medications. If we're going to start someone on analgesics, then we should reassess them within a few weeks to know if it's helping and, basically to see if it's improving function. Because if it's not improving your function, it may not be worth continuing. Of course, there are risk factors for sort of high-risk patients, and that is people that have a history of substance use. And then if they're on combined benzodiazepine, that carries an increased risk of overdose. And then certainly anybody that's had a prior overdose where they've had naloxone and got revived and everything, those would all be high-risk patients. And so we may consider not even prescribing or looking at other ways to mitigate risk. And one of those ways would be, of course, to prescribe Narcan and give them a prescription for Narcan to keep on themselves should they experience an overdose. Then virtually every state has PDMP, prescription drug monitoring. In Ohio, it's ORS, and we'll talk about that briefly. We should be doing yearly drug screens, and we should avoid co-prescribing benzodiazepines. And that should just make sense. When you're getting anesthesia for like a colonoscopy, you're getting usually a combination of maybe fentanyl and Versed. So that combination is very risky for overdose. And then if someone has progressed and they've developed opioid use disorder, then continuing to prescribe is no longer a good idea, and they should be placed on medication-assisted treatment or buprenorphine, which is really the most evidence-based therapy at the moment. So this slide just points out that Ohio law dictates what providers need to do. For the most part, this matches up with the guideline that we just reviewed. And what gets doctors into trouble with their prescribing and protecting their license is a failure to document. So we just need to clearly document conversations with patients, and that we're continuing to reassess at least every 3 months. So regarding ORS, the Ohio Automated Reporting System, and then so we have an obligation to query this whenever we do a refill or anything for greater than 7 days. One of the things for us to pay attention to is in the center here, the overdose risk score. So the higher the score, the greater the risk of overdose. And you can see the range in the center there. It's from 0 to 1,000. But what do those numbers mean? Well, you can see that they correlate with increased odds ratio of overdose death. And so anything above 200, the risk goes up substantially. And then, for 400 to 500, we see that such a patient has 25 times greater risk of dying from an overdose death than someone with a score less than 200. And then, but it's not totally straightforward what we should do. There are some recent thoughts and recent papers suggesting that if we're not careful, if we taper too quickly, especially if we suddenly stop these medications, that we could be doing some harm, because patients may seek other providers. They may also seek their meds on the street, and clearly that's not what we want to do. So, what are the harms of too rapid of a taper? So one would be withdrawal symptoms. And then, of course, we can unmask pain that was previously treated. And then we already pointed out that a lot of patients have anxiety and depression and PTSD. So if we're not careful and slow in our approach, we could aggravate those conditions. And then this was just a few months ago in New England Journal, but this paper was pointing out that many times we inherit patients, so-called legacy patients that are come to see us as a new doctor, and they're on chronic pain medications, and we're in this dilemma. We may not want to prescribe, but yet the patient's suddenly has no other access to meds they've been on for a long time. So this paper was describing that a lot of patients, I think it was California, but so they suddenly a bunch of pain clinics closed and with no warning, and there were a large number of patients, 20,000 patients, had nowhere to go, and inevitably they're going to show up in primary care doctors' offices, and then what do we do as a primary care doctor? What do we do with that? So this author suggested, here's some ways we can deal with this. In an ideal world, we would reach out to the former doctor and have a discussion with them to have a doctor-to-doctor handoff. That's not very practical. We could consider giving patients a therapeutic bridge, and I think that's very reasonable, especially for benzodiazepines, because we do know that abrupt cessation of things like Xanax could provoke a seizure and withdrawal, life-threatening withdrawal syndrome. We should always be patient-centered in our approach. And then if we're uncomfortable with the level they're at, we should consider a taper, and hopefully the patient will agree with that. But we should realize that this is going to have to be a very slow process, and that item number 3 there, successful tapers often take months or years. And then, of course, we need to monitor for opioid use disorder. If they have that, we need to figure out a way for them to get MAT. And then, of course, documentation. So, if we're inheriting a legacy patient and we decided to do these things, just document our thought process. Like, I'm doing this to help the patient. I don't want them to abruptly be cut off, and my long-term plan is XYZ. If we taper, it should be no more than 5 or 10% per month. At any point, if they're struggling, we can pause, and there's other ways we can try to minimize withdrawal symptoms. We can prescribe like a comfort pack of other medications to treat symptoms. So how can we approach this whole dilemma? One thing we can do is analogous to the drinker's pyramid. We could have the opioid prescribing pyramid, and low risk prescribing would be a low NARCS check score below 200, low morphine milliequivalents per day, which 50 seems to be a cut point that carries greater risk. And then, so if they're above that, we would consider that risky. And what can we do about that? Well, the ways to address risk would be to co-prescribe naloxone, or to engage the patient to consider a slow taper. And then, of course, if it's a high risk situation where they have a substance use disorder, then we should figure out a way for them to get MAT. Dr. Hirschberger, are you still there? And would you be willing to chime in here?
I am. Do you want to continue with your slides, or you want me to switch to mine?
It does not matter. I can scroll for you if you like.
Okay, that's fine. That's fine. So much like the SBIRT model, we've got essentially the same components in the Presto intervention. The distinction would be, we think any feedback to the patient needs to be more integrated with the enhancing motivation, because to simply say up front to the patient something like, we need to taper your medication, is likely to be met with a lot of defensiveness. So really one of the challenges with this particular cohort of patients, those who are on chronic opioids or benzodiazepines, is that typically they're not on the same page as you. They're not coming in asking for a taper, and you, from your perspective, you're seeing that they need to be tapered. And so the challenge to find common ground here can be a little bit difficult. Next slide. And so the beginning is going to be the same, raising the subject and doing some open-ended exploration. Tell me about how long you've been on this medication. How's it affecting your function? How are things for you now compared to before you were on the medication? And so you are interested in finding out their perceived benefits, then and proceed to, and what concerns do you have about being on this medication? What don't you like about being on it? It's possible that one of the answers to these latter questions could be, it's such a hassle that I have to come in every month to get a refill, or something about that. And if that's what the patient's concerned about, then that's something you're going to use. You might further say, well, and what's your understanding of why that is? To again, you want to elicit as much as you can from the patient. Next slide. And as you're doing this, you want to be continually assessing risk. So how the patient is responding to you can be useful information in terms of, are there behaviors that suggest more of an addictive pattern rather than simply a case where there's tolerance and dependence. Next slide. So the core of this is the enhancing motivation. Next slide. One of the things to really emphasize here, we talked about this with motivational interviewing, is really the base of this approach is the rapport with the patient. So you want to let the patient know that you do want to work with them, that you do have the shared goal of helping them manage their pain so that they're able to function in meaningful ways in their lives. And then as you're conversing with patients, you want to be particularly attentive to where there's emotion. What does the patient care about? What are their values? What are their goals and priorities? And also where there's discrepancy, where the patient's current behavior, particularly the current medication regimen, might be inconsistent with some of those goals. Certainly, you want to emphasize reflections, open-ended questions, and if you see a need to educate, get permission from the patient to do that, provide education in small chunks, and then elicit the patient's response to whatever information you've provided. These are just some examples of the kinds of reflections you might be using. Let's say the patient has been on an opioid regimen, they've had some increases in doses, and they're complaining that it doesn't seem to be working. So you might reflect that. So this medication seemed to have helped more in the past than it is now. Or again, depending on what the patient's saying, these are other examples. You're aware of opioid overdose deaths, but you don't see how that could happen to you. And again, the purpose of reflections is to elicit further response from the patient. This sort of follows the roadmap we talked about. What do you like? What don't you like? What concerns do you have? And then depending upon your knowledge of the patient's history, you may determine that the challenge here is to develop some discrepancy where none exists. And one of the potential strategies to do that is to inquire about the patient's awareness of certain side effects. So you might ask them, what do you know about something called hyperalgesia? And this could be particularly relevant to the patient who's had increasing doses of an opioid and is now in a position of saying, I think I need more. And when you ask a question like, what do you know about hyperalgesia? What do you know about osteoporosis? Chances are the patient can say, well, I really don't know anything about that. So that becomes a situation in which you can provide some brief education. If you have reason to believe that sexual function is going to be particularly important to your patient, you may inquire about that. And the patient may say they haven't seen any change in their sexual function, at which point you can indicate that one of the things we sometimes see with these medications is that over time a person does develop problems with sexual function. If you know your patient has an elevated overdose death risk score, you might ask them what they've noticed about their breathing. And chances are they're going to say they haven't noticed anything about their breathing. That is, unless they have a pulmonary problem, in which case this is probably not a route you want to take. But assuming there is no respiratory issue, patient's going to say, well, I haven't noticed anything about my breathing. And then you might ask them, why do you suppose I'm asking about your breathing? And the patient's probably going to say, well, I don't know. And you can say, well, what do you suppose happens to a person when they get too much of this medication? So you're sort of guiding this conversation for them and say, well, I guess what you're suggesting is a person stops breathing. Yes, that's what happens with an overdose. And then at that point, you might go ahead and pull up the NARCS check score and discuss that with the patient, that they already do have an elevated risk, and you're concerned that you not contribute to increasing that risk. For the patient where I would try to be fairly certain you don't have a patient who has suicidal thoughts for this next example, but if you've got a chronic pain patient without any history of suicidal ideation, you might ask, how much risk of overdose death are you willing to have in your pain management regimen? And most patients are going to say, well, I don't want to die, I just want my pain managed. And then at that point, you can look at ORS, the NARCS check score, and say, well, it looks like with the current medication you actually already have an increased risk of overdose death. What are your thoughts about that? So again, this is a way to try to develop some discrepancy where none existed. The patient doesn't want to die, but they're already at higher risk because of their regimen. As Dr. Berger mentioned, one of the recommendations is that you offer prescription of Naloxone to patients on chronic opioids. Mentioning that can be a way to develop some discrepancy, that the patient may think about Narcan as something that's only relevant for somebody using heroin. And so again, it might be a chance to talk about prescription opioids and the risks with them. And then you might ask the patient, what do you see as the downside to tapering? And I would start there and then finish with, and what do you see as the upside to tapering? And chances are in this conversation, the patient is going to say, well, what about my pain? How am I going to manage my pain? At which point you want to assure the patient that, yes, you do want to work with them looking at alternatives to pain management, which may include some non-pharm interventions as well as other medications. Summarize the conversation. And again, depending where you are, particularly if you've been talking about concerns regarding the current dose, then you might assess how ready the patient would be to begin a taper regimen. And I would emphasize the term slow taper. And as we talked about last week with the scale, if you get a high number on that, then you can go ahead and talk about what the regimen's going to look like. If you get a number kind of in the 1 to 7 range, you can inquire, okay, how is it you're a 6 and not a lower number, just to elicit more change talk from the patient. If you get a 0, you can acknowledge that. So it sounds like you're not at all ready to make a change. What do you think it would take for you to move from a 1 to a 2? I mean, from a 0 to a 1 or a 2. And there again, often the patient's response to that would be if something bad happens, if I begin to have problems. And then you can inquire, well, what bad thing or what problems? And chances are that's going to be some complication, some side effect, perhaps an overdose, at which point you can then inquire how important it is to the patient to avoid that bad thing happening or that problem developing. Again, if you're going to educate, you want to ask permission. With the tapering strategy, as Dr. Bricker mentioned, it's going to be a slow taper. I would probably, if you're going to use a percentage, if you're going to mention a percentage of decrease as the initial taper, I would probably say go with 10%. The reason being, if the patient's kind of resistant to that, then you've given yourself some room to go even lower. Whereas if you start with 5%, it's going to be a little bit harder to go to lower percentages in some sort of a practical manner. Next slide. And then, of course, you want to elicit the patient's response to what the tapering protocol that you're proposing. If there are challenges that the patient identifies, before you try to solve them, I would elicit from the patient their thoughts about how to deal with those particular barriers. And then you also want to summarize the benefits that you've identified to a tapering protocol. And that could include some of the specifics that will be involved as you go forward, including things like how often you're going to follow up, drug screening, and so forth. And as we used this roadmap before, we think this applies here as well. So tell me about the current situation with your pain, with your anxiety. What do you like about the current regimen? What don't you like? What concerns might you have? One thing I didn't talk about is, let's say you've got the patient who has been on chronic opioid therapy or benzodiazepines for that matter, and they have had increasing dosages in their history. You might inquire from them how long they continue that pattern, how long they could continue that pattern. And patient might say something, well, I assume you'll just prescribe what I need. And you can say, well, what would we do when we get to the point where I can't safely prescribe a higher dose? So the point here is the patient may not have thought about the potential endpoint to increasing doses. So that could be one of the things when you ask about how does this pattern look to you going forward, that you can guide them to look at. And then hopefully also guide the conversation to it being beneficial to try to get an alternative treatment plan before you get to that point where you can't prescribe a higher dosage of an opioid or a benzodiazepine. And then we've talked about the use of the scale. So with that, let's see what questions or reactions you have to the Presto protocol.
I don't like, I'll say, I don't know, are there like any data to show like how effective these two approaches are to like help individuals? Like what's the success rate of individuals like when this method is used to help them like achieve the goal that we want them to?
I can address the Presto. So we've done a study, and it's where we educated providers, and then we tried to see, some objective measurements like, how effective, what their prescribing patterns were before and after training in this. And the answer is there isn't tons of data out there. So we showed a very minimal effect, and that doesn't mean that we should abandon this approach. It sort of means that it's a challenging area and not well studied and all of the above. So anyway, there isn't a lot of data for no matter what approach you use for tapering. There aren't big studies that look at that. But despite that, the CDC guideline actually, if you go to their website and dig around, I mean, they definitely recommend tapering patients whenever possible and avoiding, prolonged prescribing whenever possible and all those things. But they really don't provide you with a lot of tools, which is why we've done more study in this with, how do you get there with patients? So.
And those recommendations sometimes will mention motivational interviewing as well, even though they don't talk about how do you actually use motivational interviewing for this particular problem. I might also mention with the study that Dr. Berker alluded to that we've just completed, that involved us getting data from the Ohio State Board of Pharmacy. And one of the things, in fact, participants in our study, we tracked their prescribing patterns for 16 months, 8 months prior to the training we provided and 8 months subsequent to training we provided. One of the things that was occurring, and to my knowledge is continuing to occur, is a slight downward trend in opioid prescribing in the state. So for us to demonstrate a significant benefit, we needed to show an even greater decrease in prescribing during that period. So kind of made our getting significant results a little more challenging since that downward trend's already in place. And then, Angie, did you want to comment on SBIRT, or do you want me to go ahead?
Yeah, for SBIRT, there's been a lot of studies done, a lot of effectiveness studies, and it's been shown to reduce unhealthy alcohol and tobacco use. And many of the same models are replicated over for depression or other mental health disorders that you can screen for. So lots of studies have been done, and it shows to being really effective.
SBIRT gets a Class B rating from the U.S. Preventative Services Task Force. So it is recommended for adults, pregnant women. Not enough evidence for them to give that rating to adolescents, although our pediatric colleagues would say there's nothing that has better evidence than the SBIRT approach with adolescents. I might also mention that there was a study published, I think it was in one of the Yale affiliated hospitals, where they used SBIRT with overdose patients in the emergency department, focused on getting them started on opioid use disorder treatment, a buprenorphine treatment. And they found that the SBIRT model resulted in a greater number of patients being willing to initiate buprenorphine treatment. And I think they followed them for 6 months. At that 6-month point, a greater percentage of those with whom they had used the SBIRT approach were still in treatment. So that's an excellent question.
And among the various diseases that motivational interviewing has been applied to, the whole area of alcohol and substance use is one where there's the greatest efficacy or evidence, I think.
Just a little bit of history there. Back in the 80s, when the motivational interviewing was first developed, the prevailing way to interact with patients with drug or alcohol problems was to be very confrontive with them. There was conversation about you've got to break through the patient's denial, and so the therapists often were pretty argumentative with patients, trying to break them down, so to speak. So for Miller and Rolnick to come along and say, we need to be compassionate, we need to elicit the patient's thoughts. I mean, it was really revolutionary. It was almost a 180-degree turn from the way in which treatment was being done at that point in time.
Thank you.
Other questions, other reactions?